Hello, and thank you for joining today's NCCN patient webinar, Know What Your Doctors Know, Pancreatic Cancer. My name is Tanya Fisher, and I am the moderator for today's webinar. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 31 leading cancer centers across the United States, devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. High-quality printed copies of the book can be purchased through Amazon. If you ordered a free book when you registered for this webinar, you should be receiving it shortly. The Know What Your Doctors Know webinars complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Gabriella Chiorian. Dr. Chiorian is Clinical Director of Gastrointestinal Medical Oncology at Seattle Cancer Care Alliance. She is also Professor, Clinical Research Division at Fred Hutchinson Cancer Research Center. Following Dr. Chiorian, we will hear from Greta Valentin, who is Clinical Nurse Coordinator for Pancreas Cancer Specialty Clinic. Our third presenter today is Cassidy Moravec, Patient Advocate. Cassidy is Associate Director, Scientific and Medical Affairs, Pancreatic Cancer Action Network, or PanCAN. Now I will turn it over to Dr. Chiorian.
Thank you, Tanya. I'll be presenting today a little bit about pancreatic cancer, some of the treatment options available, and I'm hopeful for all of you to ask as many questions at the end of our presentation. Pancreas cancer is a huge problem for healthcare, and not just in the world of cancer, but in general. We have approximately 60,000 new cases each year, and among the new cases, approximately 48,000 people die from pancreas cancer each year. And overall, for all stages combined, the 5-year overall survival is only 10%. Stage by stage, it is associated with the lowest survival among the major cancer types, and it is expected to become the second leading cause of cancer death in the United States, just behind lung cancer in the next decade. There are several risk factors for pancreas cancer, age being one of them. Pancreas cancer typically occurs in the mid-60s to the 70s. Unfortunately, we do see very young patients that are affected by this cancer, and every time we see a young patient, we wonder whether there may be a hereditary predisposition genetic risk factor involved. Men are slightly higher risk than women, and Black people are at a higher risk than white. Smoking is a risk factor, obesity, long-standing diabetes, diet, chronic pancreatitis, and actually certain exposures of chemicals. In the Czech Republic, for example, arsenic exposure is a very high risk factor for pancreas cancer in that part of the world. As I mentioned briefly, 5 to 10% of the time, pancreas cancer occurs due to a genetic predisposition syndrome, the most common being the BRCA1, BRCA2 gene mutations, a little bit of Lynch syndrome, which is mismatch repair deficiency or MSI high, Peutz-Jeghers, familial atypical mole melanoma syndromes, and several others. People that have one family member that had been affected by pancreas cancer have a 4 to 5 times higher risk of developing pancreas cancer. If 3 or more family members were involved, the risk goes as high as 30 times higher than the general population. What about localized disease? Approximately 30% of patients have localized pancreas cancer. Among them, about a third can be easily resectable upfront, but the rest, the cancer unfortunately cannot be removed because it wraps around the blood vessels. Next, I'm going to show you the complex anatomy of the structures in and around the pancreas. This yellow gland that spans the upper abdomen from the right to the left is the pancreas gland. It has a head, a neck, a body, and a tail. And the tail is close to the left upper quadrant of the abdomen, close to the spleen. And the head is basically situated and surrounded by the small bowel, by the duodenum. And bile ducts run right through the head of the pancreas. And therefore, when a tumor occurs in the head of the pancreas, oftentimes patients turn yellow, jaundiced, and that's a sign of a possible tumor in the pancreas. There are multiple blood vessels, both arteries in red and veins in blue, that you see around the pancreas. And again, when a tumor occurs, oftentimes in the head of the pancreas and is encasing some of these structures, a surgeon may be having a very hard time removing the tumor. And that's what we call borderline resectable or locally advanced cancer. It's a situation where we can't do surgery up front, but sometimes we need to treat the cancer with chemotherapy and or radiation to try to shrink it and then try to remove it. This is an example of a CT scan axial image. This is basically a horizontal cut through the whole abdomen. And here you see the liver on the right, you see the two kidneys and the spine in the back. And the bowel are these loops filled with material. And the pancreatic tumor is labeled with a yellow T. And we see these two blood vessels here, very tiny blood vessels, and a black space, which is fat, in between the tumor and the blood vessels. This is exactly what we want to see to determine that this tumor can be actually removed easily. It's not attached to the blood vessels, and this should be a resectable tumor. I'm going to give you an example of a patient, a 55-year-old woman who successfully underwent surgery for approximately 1 inch, 3 centimeter pancreatic mass, pancreatic cancer, and she recovered well from surgery. CT scans show no evidence of spread to other organs, so no metastases. And there are certain types of chemotherapy. These are agents that are infused through the blood, and they go everywhere where cancer is, including the pancreas. And in case tiny cancer cells have spread from the tumor in the blood, this chemotherapy is supposed to kill those cancer cells and, so to speak, sterilize the blood and prevent the cancer to come back. We do know that there is evidence that without chemotherapy, pancreas tumors typically come back at an average of 6 to 12 months after surgery. So it is a standard of care that all patients after surgery receive some sort of chemotherapy to prevent the cancer to come back. Now, the question is, what is a standard chemotherapy for a healthy patient that has a successful operation? Do we use a single agent called gemcitabine? There is a doublet chemotherapy combination called gemcitabine and capecitabine. There is a more aggressive cocktail of drugs called Folfirinox, which is 3 chemotherapy drugs together, or another doublet called gemcitabine with nab-paclitaxel. And the gold standard is actually this cocktail, the Folfirinox medication triplet. It has shown in a clinical trial in 2018, published that it's significantly better than single agent gemcitabine. Gemcitabine has been around since 1996, and it has mild benefit towards pancreas cancer. We still use it. We use it a lot, especially for patients that are more frail, that are unable to tolerate aggressive chemotherapy. But for someone who's healthy and robust, we would recommend the most aggressive means, because why? We accomplish a 30% improvement in overall survival with a median survival of approximately 54 months with Folfirinox, comparing with only 36 months with gemcitabine. So there is a superiority in survivorship as well as delay until the cancer returns, and that's called disease-free survival. It's the time from when we do the surgery until the cancer recurs. And the disease-free survival with Folfirinox was approximately 2 years, approximately 22 months with Folfirinox, and only 12 months, only 1 year with using gemcitabine. So again, this is an aggressive cancer. Even with using chemotherapy, we still see high rates of recurrence. So again, the answer is Folfirinox for a patient who's healthy and able to tolerate it. What about the situation where the cancer is really too close to blood vessels? To the left, we have a scan that shows that the tumor here with the red arrow only touches on the superior mesenteric vein and the artery behind it. And to the right here, we see a tumor that completely surrounds 360 degrees around an artery. This tumor cannot be removed, and the tumor on the left could be removed, but the cancer will be left behind because a surgeon cannot peel it off the artery. So you don't want to do a surgery unless you can completely remove it. You don't want to leave any tiny cancer cells behind. So we call borderline resectable to the left, locally advanced to the right. How do we treat these tumors? We still offer them aggressive chemotherapy because we have high hopes that many patients can become resectable with successful operations. This is an example of a patient of mine. You see here with a tumor that is completely 360 degrees around the superior mesenteric artery and approximately 180 degrees around the superior mesenteric vein. And she's 64. She has a 3.5 centimeter mass. She does have some family history of breast cancer, but nobody had pancreas cancer. She has a good performance status, means she has some pain, she has a little bit of fatigue, but she's still able to do all her activities of daily living. In a patient like this, we always question whether could there be a hereditary component. As I mentioned to you, the BRCA1 and the BRCA2, the BRCA genes, confer a risk of pancreas cancer, and those same genes also confer a risk of breast cancer and ovarian cancer. So it's possible that in the family, nobody had pancreas cancer, but there may be family members with breast cancer. That raises a red flag. Nevertheless, we did test the patient. We did a blood test to check for germline hereditary genes, and she tested negative. What did we do? A patient underwent chemotherapy. She did receive Folfirinox indeed. She did have toxicities, but we pulled through the toxicities. We made adjustments to the chemotherapy. We reduced the doses, 20%, sometimes 40%. It's okay to reduce the chemotherapy dose. It still can work. And this patient had 40% chemotherapy dose reductions, and she still had a significant and robust shrinking of the tumor. It shrank to less than 180 degrees, maybe just 90 degrees around the artery here. And we also pursued with radiation therapy called stereotactic body frame radiation, or CyberKnife. And after this 6 months endeavor of treatment at the multidisciplinary tumor board, where we review all of our patients, because more brains are always better than one, and we have our surgeons, the radiation doctors, the radiology doctors, etc., all make a decision of what's best for each patient. And we decided that, this looks really good. Let's try and explore. And if we can, let's remove that cancer. So the patient underwent a Whipple operation 3 weeks after radiation. And to make this understandable to all of you, despite the fact that the mass that was removed was 5.5 centimeters, approximately 2 inches, the mass was almost entirely scar tissue. There were very, very few cancer cells left. The viable cancer was less than 5%. and none of the lymph nodes, 16 of them were removed, had any evidence of cancer. This patient is a patient who had locally advanced stage 3 cancer and had a successful margin negative resection and is alive without cancer 6 years later. What about metastatic disease? Most of our patients, unfortunately, more than 50% have advanced metastatic disease, which means it's spread to other distant sites at diagnosis. This is a patient who not only has a tumor in the pancreas, which is fairly large here in darker gray, but also has these many spots, these darker spots in the liver. And unfortunately, a liver biopsy was done, and it was consistent with pancreas cancer. We can biopsy a distant organ and can tell under the microscope where the cancer started by using appropriate stains. This patient also needed to have a stent because there was a blockage of the bile ducts by the tumor, and the bilirubin, which was very high to begin with, improved and normalized. This patient has not a perfect, but a good performance status, able to sustain chemotherapy. And what is the optimal treatment option? Again, we don't have an infinite option of chemotherapy in pancreas cancer. Gemcitabine, again, is something that we use in more frail patients if they're interested in treatment. Gemcitabine and nab-paclitaxel is another regimen that has been studied for metastatic disease with success in an international clinical trial. Folfox is an option of a chemotherapy that's not quite as intense as Folfirinox, but it's still, an option for some patients. And the other option is, it's really the patient's choosing what they want to do. And B and D are actually both NCCN guidelines sponsored and really vetted chemotherapy regimen. So it's more a matter of what side effects these regimens confer to the patient, and the patient decides what they feel they want to be treated with. The oncologist just needs to advise the patient on the options. So really in yellow, we have the treatment options for first-line treatment of metastatic disease. Some of them I've already mentioned. The new kid on the block is called olaparib. And olaparib is a pill PARP inhibitor. This is a targeted therapy which may work to delay cancer progression for patients that have hereditary germline BRCA1 or BRCA2 genetic mutations. So again, we wouldn't know if a patient has these gene mutations unless the patients get tested, and it's standard of care for all patients, any stage of disease, to have germline testing for mutations. In purple below are the treatment options for second line and beyond. Liposomal irinotecan and 5-FU has been approved in 2015. Pembrolizumab is an immune therapy which has no benefit for pancreatic cancers in general, except for 1% of patients that have Lynch syndrome or MSI-high cancers. This is a very, very rare mutation, but unless we test each patient, we would not know who has it and who doesn't. These patients may benefit from pembrolizumab, an immune therapy. Pembrolizumab has been approved in addition for patients with tumors with high mutations of DNA per each megabase. It's called high tumor mutational burden. Again, this is part of the genetic testing, and we need to determine who has this high TMB. NTRK is a gene fusion that occurs very rarely. Again, it's approximately 1%, but it is worth knowing who that 1%. All it takes is 1%. And these treatments, larotrectinib and entrectinib, both have tremendous benefit with response rates of 60%, way better than any chemotherapy we have for pancreas cancer. Not only that, but extremely durable. When a response occurs with these treatments, it can last for longer than 2-3 years. Responses with chemotherapy typically last for 6 months, and then the chemotherapy loses efficacy. So again, I cannot emphasize enough the need for genetic testing, both germline, meaning in the blood or saliva to see what's hereditary, but also to test the tumor for genetic mutations because many mutations only occur in the tumor. So we need good tumor biopsies to be able to test. Treatment sequencing. Basically, we have two options. In blue, if a patient starts metastatic disease therapy with gemcitabine and nab-paclitaxel, also called Abraxane, first, the median survival is approximately 1 year, whether you start with Folfirinox or whether you start with gemcitabine and nab-paclitaxel. Second line, depending with what you start with, you go to a 5-FU-based regimen. If you start with gemcitabine, and you go to a gemcitabine-based regimen if you start with Folfirinox. And keep in mind, every step of the way, clinical trials should always be considered first, because why? There is never a placebo component. Everybody on a clinical trial will have access to the standard treatment and plus or minus something new. So that is a way of finding new agents for pancreas cancer. All of these regimens that we see here that really improved survival in the last 5 years from 6 months to 12 months. And for many patients that live more than 2 years, about 25% of people these days live more than 2 years. 10% of people with metastatic disease live more than 3 years. It all depends on treatment options and on clinical trial participation and finding new drugs. So we highly encourage both ASCO, the American Society of Clinical Oncology, the NCCN, PanCAN, all of us as physicians and nurses, we encourage people to participate in new clinical trials. Special molecular subsets, I mentioned the BRCA1 and 2. This is a data with olaparib. I mentioned that olaparib can delay disease progression. And this treatment is used after patients originally gets treated with chemotherapy with platinum. So either Folfirinox, which has oxaliplatin, or something called cisplatin with gemcitabine. So as long as they have a platinum-based chemotherapy, patients may benefit to receive a maintenance, like stop the chemotherapy and have a break from it and receive maintenance with olaparib. So there is benefit for that. In addition, I mentioned the pembrolizumab, the immune therapy, which applies only to patients that have high mismatch repair deficiency, meaning their DNA cannot be easily repaired and they have a higher degree of genetic mutations. Pembrolizumab has been tested in a clinical trial here to the left, which included 22 patients with pancreas cancer. Response rates were not very high, but still 18% the response rates with immune therapy alone with no chemotherapy is still beneficial. The progression-free survival was only 2 months though, and the survival rate was median of only 4 months. So again, immune therapies are not the panacea, and we're doing a lot of work in combination therapies with immune therapies to figure out who truly benefits, and also how can we combine these immune therapies with novel agents to make them work better. To the right, we have the high tumor mutational burden, which unfortunately in this study of more than 100 solid tumor patients, no patient with pancreas cancer had a high tumor mutational burden more than 10. So again, if there are patients out there with a high tumor mutational burden, there may be benefit from pembrolizumab, which is also called Keytruda. Here we have another example of targeted therapy for pancreatic cancer. I mentioned the NTRK, the NTRK fusions. In this waterfall plot, every bar going down, meaning the cancer is shrinking, and that's what we want to see. And this is a patient, actually 2 patients with pancreas cancer among many other solid tumors, that both of them responded with larotrectinib with response rates of more than 3 years. And this in the middle, we have an example of a patient with multiple liver metastases treated with entrectinib that had a complete response in the liver. You see the liver metastases melted away, and the progression-free survival, the time to progression was almost a year here. And to the right, we have something called an ALK mutation, which is more common in lung cancer. It may rarely occur in pancreas cancer as well, and patients benefit from ALK inhibitors. These agents are available on the market. This is a new therapy called zenocutuzumab. This was just presented at ASCO 2021, and it's for patients with pancreas cancer that have something called an NRG or neuregulin fusion gene. And again, very important novel discovery that this agent, which is a type of immunotherapy, it's bispecific antibody, attaches to the target and tries to block its effects on the tumor. This is now available only in the clinical trial setting, but again, we are hopeful that the FDA would look at these results favorable, and hopefully the end results will be that a new drug may be approved for this subset of patients. This is to show you that the Pancreatic Cancer Action Network published a registry of data about 700 patients that had molecular testing, and about 30% of the patients, about 200 almost, had actually actionable mutations. But among those patients, only about 50 of them were exposed to matching therapies. So it's not enough to test if we don't have access to the drugs, to the clinical trials, that we can target these alterations. So when patients received matched therapy according to their mutation, their survival was double, comparing with patients that had no targetable alterations, or they had them, but they didn't benefit from having access to the right agents. So the survival was almost 2 years here for people that received matched therapies. So I also want to emphasize that the need for palliative care. Palliative care is not hospice. Palliative care is taking care of the patient, of the symptoms, of the pain, the diarrhea, the bloating, the fatigue, nutritional support, etc. So palliative care should be used as soon as possible after diagnosis if a patient has any types of symptoms. I cannot emphasize this enough. You don't need to wait until the symptoms become intolerable or you exhausted the cancer therapies. There are many types, again, of palliative care, having to do with relieving the bile obstruction with a stent, treating with pancreatic enzymes, which help bloating and diarrhea and gas pain after eating, managing the diabetes, using nutritionists and potentially appetite stimulants, or counseling with a nutritionist, treating the pain, and potentially doing a nerve block, which sometimes can be successful. So again, in summary, the combination therapy called Folfirinox is a standard of care for any patient who's healthy and robust and has recovered well after surgery. And typically we treat for 6 months. Approximately 60% of people can tolerate 6 months, but we'll take any amount of time that we can to give adjuvant chemo because it helps prolong survival. Chemotherapy alone at this time is a standard for localized cancers that are close to blood vessels. But on a case-by-case basis, we use radiation to help solidify the local response. For metastatic disease, either Folfirinox or gemcitabine and nab-paclitaxel are the standard of care because overall survival is approximately 1 year with either modality. In second line, the FDA-approved regimen is called liposomal irinotecan and 5-FU, but we have data that even the standard irinotecan with 5-FU called Folfiri and Folfox can also benefit. Immune therapies, pembrolizumab, only works modestly for patients that have MSI high status. So when patients come to me and want immune therapies for their pancreas cancer, unless we are studying them in combination approaches in clinical trials, they will not work for the patient. So we need to use these therapies in a setting of a clinical trial, not by themselves. Maintenance olaparib is an option after you already have a response or stable disease from platinum chemotherapy, as long as the tumor has a germline BRCA1 or 2 mutation. And every patient should have germline testing for hereditary gene alterations as well as a tumor somatic mutation. Palliative care is essential. Thank you so much for your attention. I will now give the floor to the best nurse I have the privilege to work with, who takes care of our pancreatic cancer patients and serves to coordinate our multidisciplinary pancreas cancer clinic, Greta Valentin. Greta, take it from here.
Thank you, Dr. Kurian. Good morning. My name is Greta Valentin. I'm the clinical nurse coordinator for the Pancreas Multidisciplinary Clinic at the Seattle Cancer Care Alliance. And I'm going to start with my first slide here. We have a clinic here that we do twice a week. And the guideline that we go by, clearly NCCN, is that all patients should at some point get a multidisciplinary consult. And we see patients even before a pathological diagnosis. So when there's a suspicion, often they're referred to us. If there's a symptom or something that's come up, we get referrals from a variety of folks. We often start with a pancreas protocol CT to evaluate the tumor in the abdomen completely. That's usually followed by staging, if needed, chest and pelvis. The group meets, and we, by group, I mean 20 to 30 of us in the team. So that includes medical oncologists like Dr. Kurian. We have surgical oncologists in that group. Our radiation oncologists are there. We have a radiologist who specializes in reading these pancreas protocol CTs and presents the actual images to the group. We also have in that team our palliative care nurses, our genetic counselors, our nutritionists, social work. We have chaplains in there. So everyone is around the table to kind of determine what their piece of caring for that patient is going to be and when. We don't all necessarily descend together on day one, but at some point, most of those people will come into play and be part of the care trajectory. So following that discussion, we really are determining whether there's metastatic disease present or not. And if not, we move on to, like I said, getting further imaging. Often we have to involve our GI colleagues and get an EUS and a biopsy, sometimes a stenting if people are having obstruction, jaundice, things like that. Sometimes we need to further evaluate the liver and order MRI, which then we might review at a later time together as a team. We look at labs, talk about any germline testing, things like that. If there is metastatic disease, then often our radiology colleagues will help us determine if there's a lesion that's amenable to biopsy, and we move forward with that and getting as much sample as we can and to ensure we can do this gene profiling and germline testing. For people that are not metastatic, we then as a team talk about where they are. Are they resectable? Are they borderline, locally advanced? All similar to what Dr. Kurian had mentioned in her previous scans, or I'm sorry, slides. And then what is the plan from there? So I think this slide really is meant to show the value of this team approach, and that having multiple people involved looking and questioning each other, asking each other why is really the best and the guideline that we should be following. This was a study done that really looked at how there is improved survival in a variety of different cancers and also in pancreas when patients do get a multidisciplinary review, and that it is the gold standard of care, and that it can really impact decision making and planning and treatments moving forward. This is a study done out of Italy, very current, 2021, and showing the impact of a multidisciplinary team on the management of pancreas cancer. These colors here show a variety of things. So the cystic lesions kind of in the lime, IPMN, which we know is often a precursor for malignancy, and then pancreatitis, and then cancers are in the blue. And this slide kind of just emphasizes how when a case is reviewed in a multidisciplinary tumor board, that it can change diagnosis. And sometimes we go into the conference thinking, oh, this is a cyst or this is an IPMN, and ultimately, due to everyone's expertise and evaluation and review, that can change the diagnosis. It can change whether someone could be resectable or not. And so just to make sure that we are really evaluating as a group and looking at all the pieces. This is our team here at the Seattle Cancer Care Alliance. Like I said, we get a variety of referrals. We see about 250 people a year. We have clinic on 2 days a week. We get patient referrals. We get referrals from community oncologists wanting to know if there's eligible trials for patients. We get primary care provider, GI referrals, and this is my part here. We do a lot of review of record ahead of time with input from these specialists, even prior to the multidisciplinary review, determining if referrals need to be placed and trying to do all that within a week. And ordering imaging, ordering slides, things like that, and then having this review where 25 of us sit around the table and really take a dive into each patient's imaging, pathology, symptoms, labs, etc. So this is kind of the flow of that. Really, the goals from our multidisciplinary review are determining whether a patient is potentially resectable, recommending any other diagnostic tests that might be necessary, recommending treatment before surgery to improve resectability odds, mostly for borderline and locally advanced, and metastatic as well. Comprehensively evaluating the patient's goals. Everyone comes to us with a different set of goals, and it's our job to tailor our treatment to match that. We also do a lot of recommendations in the area of pain management and palliative care, managing symptoms of chemo, and trying different things. We have arsenals of meds and options and hydration and different things we can do to improve quality, whether it's during chemo or after. And then genetic counseling and testing for families, history and hereditary syndromes. We also try to ensure that any genomic profiling is ordered up front. Like I said, our radiation oncologists are involved in the start of the conference, and we have a lot of GI specialists that help us with, decompression or biopsies, things like that. We are always evaluating the eligibility of for patient and clinical trials, and what we have open for each disease stage. We record our visits and provide a USB stick at the end because we know we like to talk a lot, and patients really have given us feedback that they benefit from the ability to hear back about some of the options and suggestions. We provide PanCAN information at the start with nutrition and overview in a patient packet that everyone gets, and all of our supportive services are also included in there. I think I talked about genetics. So I will turn it now over to Cassidy, who will complete our talk today. Thank you.
Thank you so much, Greta. So today I will touch on a little bit around patient advocacy organizations, as well as some information on getting organized after diagnosis and some helpful resources for patients. So as far as patient advocacy organizations go, there are a handful of them specifically working and dedicated to pancreatic cancer. And I will be touching on the Pancreatic Cancer Action Network, or PanCAN, where I work as the Associate Director of Scientific and Medical Affairs. And so the advocacy organizations out there definitely have a number of different focuses. For the Pancreatic Cancer Action Network, we really take a comprehensive approach to supporting patients and their families. So we are dedicated to improving the lives of pancreatic cancer patients through our research and clinical initiatives, which includes funding research grants, as well as running our own clinical studies. We also have a government advocacy area of the organization, which really focuses on asking for more federal funding for pancreatic cancer research, because most of the research done for pancreatic cancer is at the federal level. And we just had our PanCAN Action Week earlier this June, being able to talk to a number of congressmen and women on the Hill. We also have our patient and healthcare professional services, which really are dedicated to providing resources to patients, caregivers, family members, and healthcare professionals about pancreatic cancer, providing all of the information free of charge to those individuals. And then we also have our community engagement team, who really focuses on raising awareness and funds for pancreatic cancer. And that is really led through over 50 affiliates throughout the country that are all volunteer run. Our volunteers do a wonderful job of getting the word out there and also putting on virtual and soon, hopefully again, in-person fundraising events. So just to touch a little bit on getting organized after diagnosis, and a lot of patient advocacy organizations, including PanCAN, can provide as a resource for helping patients and their families getting organized after diagnosis. So the first piece is really to learn the basics about your diagnosis, learn about what pancreatic cancer is, what specific type of pancreatic cancer you have, what specific stage, as Dr. Kioran went over the different stages. There are 4 different stages for pancreatic cancer and different treatment options based on those stages. It's also important to know about any germline genetic testing results, any molecular profiling or biomarker testing results, so you know the specifics of your cancer, and we'll get into more of that in a minute. And also just to be informed about pancreatic cancer, what are the treatment options, the clinical trials, the resources available to you, and definitely reaching out to patient advocacy organizations like PanCAN can help you with that. As the other presenters also mentioned, seeking a second opinion. So seeking an opinion from another healthcare professional who is versed in pancreatic cancer, specializes in pancreatic cancer, is absolutely recommended. It's important to get options from other healthcare professionals, other doctors, and I believe really if you feel your doctor would be offended, most doctors aren't offended. They welcome additional input from other doctors to be able to really give you a whole picture of what your treatment options are, which leads me into learning about your treatment options from your healthcare team, from patient advocacy organizations, from the NCCN materials as well. And then also, as Greta touched on, discuss your goals with your healthcare team so that your healthcare team, the multidisciplinary panel, really can understand what your goals of treatment are. Are you wanting to have a treatment that has limited side effects? Are you wanting a treatment that's aggressive? Are there life milestones coming up, like events for grandchildren or weddings, or those types of things that you'd like to be able to be around for? So really just discussing all of your goals with treatment with your healthcare team so that you can make informed decisions together. And then I will also touch a little bit in the next slides about getting onto the right track. So PanCAN has a patient services helpline, and it's been around for a number of years, since the early 2000s. And we really have always focused on getting patients on the right track, which really is focused on getting patients to the right team. So seeing a pancreatic cancer specialist, getting patients the right tests, which are those biomarker testing and genetic testing for inherited mutations, getting patients the right treatments, which includes knowing all of your options, including knowing about clinical trials that are available, as well as matched targeted therapies based on the biomarker testing and genetic testing, and then also sharing patient data at every step. And there are a number of places where patients can share their information and their experiences with pancreatic cancer, including PanCAN's patient registry, and also a number of institutions have their own registry as well. So to dive into the right team, as we've touched on a couple of times, it's really important to access experts and centers who have extensive experience in treating your specific type of cancer, in this case, pancreatic cancer. And there actually has been research to show that consulting with a pancreatic cancer specialist actually can improve patient outcomes. We've talked about seeking a second opinion. We've talked about really getting to an institution or a hospital that has a multidisciplinary team, and a number of those institutions that are treating pancreatic cancer patients at a high volume do have this multidisciplinary team approach that Greta described. Also important to note, in the current world, consultations can really be done via telemedicine, so you don't necessarily have to travel to an institution if there's not a high volume pancreatic cancer hospital close to you. A lot more hospitals now are providing access to their consultations via telemedicine, so definitely ask about that. It's important to prepare for your appointments with the healthcare team. So write down a list of questions. PanCAN has resources on questions to ask your healthcare team, as well as the NCCN has another list of questions. And also, it's sometimes helpful to take a caregiver with you. As the restrictions hopefully are lifting across the country, I know sometimes we weren't able to take caregivers with us when we went to appointments during the pandemic, but as that's loosening up, definitely encourage you to take a caregiver to be a second set of ears. And also ask even your doctor if you can record the conversation to be able to refer back to later. And it's always important to keep your doctor informed of symptoms and side effects that you're experiencing, so that they can help mediate those symptoms, help provide that palliative or supportive care to help alleviate those symptoms and side effects, as well as even considering reducing the dosing of the chemotherapy. As Dr. Curian mentioned, you can even reduce the doses of the chemotherapy and still have effective chemotherapy treatment. So it's important to keep that dialogue open and let your doctor know how you're feeling. It's also important to let them know any vitamins or supplements you're taking, because they can have some interactions with some of the chemotherapy and other treatments used for pancreatic cancer. And really, when it comes to finding the right team, you can reach out to PanCAN, and we can actually provide you a list of specialists for pancreatic cancer. So that leads me into the right tests, and this is really about getting the information, the tests, and the precise diagnosis to know all of your treatment options and make the right treatment decision. And patients with matched therapies, as Dr. Curian touched on, that have matched therapies that are selected through biomarker testing, genetic testing for inherited mutation, can actually have better outcomes. And genetic testing for inherited mutations is recommended by the NCCN guidelines for all patients diagnosed with pancreatic cancer. And then biomarker testing of the tumor tissue is recommended for all patients with advanced pancreatic cancer. So those patients who have locally advanced unresectable disease, as well as those patients who have metastatic disease. And when it comes to accessing the right tests, institutions absolutely can provide this testing. PanCAN also has our Know Your Tumor Precision Medicine program that is a biomarker testing program available to patients who may not otherwise have access to testing. So I encourage you to reach out if you have questions. And to talk a little bit about our Know Your Tumor program, which is that precision medicine service. This is the same information that Dr. Curian shared earlier, but just a little bit different perspective. So really, this was talking about the same study, patients who received matched therapy who had an actionable mutation, people who received unmatched therapy who had an actionable mutation but didn't have access to the targeted therapy, and then patients who didn't actually have an actionable mutation. And what we found, just a little graphic here on the right, is that patients who had an actionable mutation and went on a matched therapy actually had about a 1-year survival over the other 2 groups. So this is really why it's important, even though those genetic mutations, those biomarkers sometimes are very small percentages of patients. Oftentimes only 1% of patients fall into each of these different buckets of biomarkers and treatments that are available. But if for those patients that have those particular mutations, the treatments can really help improve their survival in the long run. So that's why it's important to really undergo that genetic testing and biomarker testing to make sure that patients know all of their options. And so that leads into the right treatment. So based on those biomarker results, based on that genetic testing results, being able to really identify what is the best treatment plan for the patient, for you, for identifying clinical trials. As Dr. Curien mentioned, a number of clinical trials are really focused on patients who have specific biomarkers. There are also a whole group of trials focused on patients who don't have specific biomarkers. So there's definitely clinical trials out there for a number of different scenarios. And there also are matched therapies available outside of clinical trials, as Dr. Curien mentioned, that are actually FDA approved across different cancer types, including pancreatic cancer. And we know from the research that pancreatic cancer patients who participate in clinical trials actually do have better outcomes. There's a lot of different resources provided for clinical research, and patients really have access to really great care through clinical trials. Not only novel treatments, but also they're being followed very closely by the research team. And it's important to really consider clinical trials at diagnosis and at every treatment decision, as we've touched on a couple of times here, and to ask your healthcare team or reach out to PanCAN to find what clinical trials might be available to you. So I wanted to touch a little bit on what are clinical trials. I know we've talked about them, but just wanted to dig into them a little bit more. So really they are research studies that are testing new treatments, new screening or prevention tools for pancreatic cancer in this case. And they really are important for the development of new treatment options. All of the treatment options shown on one of the earlier slides actually are available because they were studied in clinical trials and because patients participated in those clinical trials. And it's really important to participate in clinical trials so that we can determine if treatments being studied in clinical trials are safe, as well as better than the current treatment options that we have out there. Again, clinical trials should be discussed at diagnosis and during every treatment decision, and they absolutely should not be considered a last resort when the standard of care options are no longer available. As we've touched on within the NCCN guidelines, clinical trials are recommended throughout care. And you can access clinical trials through academic medical centers, the National Cancer Institute designated cancer centers are also a place to go for clinical trials, as well as there's a number of community cancer centers now that are also working in collaboration with those academic medical centers to provide clinical trials to patients closer to home. And as I mentioned, you can talk to your healthcare team. You can seek a second opinion at a hospital performing clinical trials. You can reach out to advocacy organizations. And then there's a number of clinical trial finders, including PanCAN's clinical trial finder, which is clinicaltrials.pancan.org, which are all great resources for finding clinical trials that you may be eligible for. So just to touch a little bit more on some of the additional resources available through PanCAN. So our patient services helpline is really a premier source of quality, reliable information for pancreatic cancer patients, caregivers, and healthcare professionals. So I touched on a number of these, but wanted to touch on a few more. So we do have information on support, so getting in contact with other patients with pancreatic cancer, other family members of patients with pancreatic cancer, including our survivor and caregiver network, where you can be matched directly with a patient or a caregiver of a patient with pancreatic cancer. We also have information on diet and nutrition. I know we touched on that, and supportive care both are essential in pancreatic cancer care, knowing how to manage some of the symptoms and side effects that comes along with pancreatic cancer. We also have information on early detection and risk factors, as well as information on financial and insurance resources that are available. So just to wrap up, just wanted to provide some information for PanCAN, so you can reach out for free personal one-to-one support with our case managers. Our helpline number there, as well as our email address. So please feel free to reach out. And I will end there and hand it back over to Tanya to moderate the Q&A.
Great, thank you so much to all of our presenters. The Q&A session will begin shortly. You may now submit your questions to the presenters. The NCCN Foundation would like to also thank our corporate supporter, AstraZeneca, of this webinar. I had pancreatic cancer. My mom had lung cancer, 50-year smoker, no other family cancer. I am worried about my brother. Where should he start for getting tested?
Good question. So first of all, we never test family members without testing the patient who had cancer first. So your brother does not need to be tested, but the patient who has pancreatic cancer should be tested for any genetic predisposition syndrome. Again, that's what we call germline hereditary cancer testing. Keep in mind that smoking is, again, one of those risk factors that can cause both lung cancer and pancreas cancer. So it is possible that there is no genetic link between the patient's pancreas cancer and the mom who had lung cancer. They are not part of a cancer syndrome per se. So again, we've never advised a family member being tested before the cancer patient being tested. If, let's say, the cancer patient is tested and comes back positive for a hereditary gene mutation, then any family member can subsequently be tested for that particular gene to see whether they share the genetic predisposition. But we do not recommend testing family members without testing the patient first to know whether there is or not a genetic predisposition syndrome. And insurance should cover the cost of genetic testing for the patient with cancer.
And so, Dr. Kurian, to follow up with that, I guess then if you have concerns about family history of cancer, that would be something you would discuss with your primary care provider?
So if a patient doesn't have cancer, but they have a family history of cancer, indeed, they should discuss with their primary care provider whether that particular cancer has a risk of being genetically inherited. And again, if the family members are still alive, they should be the ones being tested. If, let's say, I'm giving you the example of President Jimmy Carter. President Jimmy Carter came from a history of both mom and dad, several sisters and brothers, all had pancreas cancer. And because we have no screening test for pancreatic cancer, there are several international clinics that screen patients for pancreas cancer, but they screen so independently. There is no screening guideline. We have a screening clinic at Fred Hutch Seattle Cancer Care Alliance with Dr. Terry Bradnall. Those patients undergo yearly MRIs alternating with endoscopic ultrasounds of the pancreas to look for precancerous types of lesions, precancerous IPMNs, intraductal papillary mucinous neoplasms, mucinous cysts that look suspicious. So that's how we screen for patients that had a family history, but those family members cannot be tested because they are unfortunately no longer alive, or they simply cannot have access to testing. There is no screening test, there is no biomarker that we can screen the general population because none of them have proven to be completely reliable.
Thank you very much. So here's a question about the slide where you had the first line and the second line treatment arrows. And I don't know, Mark, if we can go back to that slide. So second line arrow, only effective if the cancer is genetic. I guess that's the question. Are the options that are shown in the second line arrow, oh, hold on. Only
If you
effective if the
can give me
cancer is
control,
genetic.
I can show the slide because that slide did not mean to show that second line is effective only when the cancer is
see.
genetic. By no means, that was not the case.
Yeah, let me get you there. Let's see. Oh,
I can, if not, I can tell you exactly what the slide said. So the first line options are either gemcitabine-based chemotherapy or 5-FU-based chemotherapy. And we say gemcitabine Abraxane is typically what we do, or Folfirinox. If you have gemcitabine type chemotherapy, the second line is typically you go to a 5-FU-based chemotherapy, and that can be Folfiri, liposomal irinotecan 5-FU, Folfox, even Folfirinox. So the second line therapy, if you start with gemcitabine, by no means is genetic. So the second line, the genetic groups are very tiny. Like I mentioned, 1% of people have access to pembrolizumab, 1% to larotrectinib or entrectinib. So the genetic groups are extremely small. This is the slide with the arrows that I had in mind. This is how we sequence. The first line is on top, second line in the middle, third line in the bottom. So the second line regimens are really dependent on what you get in first line. You don't need to have a genetic predisposition by any means to have access to second line and even to third line. So again, 5-FU-based therapy, if you start with gemcitabine first, if you start with orange with Folfirinox, then in second line is gemcitabine, nab-paclitaxel, gemcitabine, and of course, clinical trials. In fact, nowadays, we have clinical trials for third line pancreatic cancer. So these are not only for genetic predispositions by any means. The previous slide only showed the most recent FDA approvals, but these regimens here, which are all chemotherapy based, they are standard of care. They are part of the NCCN guidelines, and this is how we sequence therapy. Thank you for the question and needing to clarify that. Thank you.
thank you. So Greta, I think this is for you, that you mentioned a chaplain was at your multidisciplinary meetings. Do you have palliative care involved as well?
Yes, they're all there. So palliative care, we have some nurses and some nurse practitioners. So they're part of the discussion and often say, you know, it seems like they're having a lot of symptoms, or they've really been struggling with pain or nausea, and then we'll make sure they get looped in.
Okay, thank you. Are there any statistics regarding pancreatic cystic tumors believed to be benign then progressing to malignant behavior?
Yeah, of course. So like Greta had shown, depending on who really looks at the CT scans, in fact, some cystic lesions have cancerous characteristics on CT. So it's very, very important for radiologists with expertise in pancreas cancer to actually evaluate these lesions. IPMNs, introductory papillary mucinous neoplasms, have depending on the type of IPMN, have different risks of becoming cancer, from 1% per year to 2 to 3% over 10 years. So every lesion is different. And oftentimes when we do follow-ups, we may recommend another scan in 6 months or in 1 year. We actually observe differences in the speed, in the biology of that cystic lesion, and whether it changes characteristics, attaining maybe even a solid component to it. So that's exactly why all of these lesions are very important to be characterized and reviewed in a multi-D pancreas cancer tumor board, even when we don't think they are cancer yet, because we can really estimate their risk and the speed of progression, and whether these benign looking tumors may actually be needing to be removed versus observed.
Okay, thank you. I was prescribed glutamine powder and alpha-lipoic acid for a mild neuropathy of my fingers. Is this okay to take with Folfirinox?
I am not aware of any benefit from glutamine powder or alpha-lipoic acid for neuropathy. The best data that we have to prevent neuropathy is actually patients holding on to ice packs while they get their nab-paclitaxel or oxaliplatin chemo. So literally, while you're getting the 2 hours or so of chemotherapy, you hold on to cold ice packs in your hands, alternating 1 or 2 minutes each, because that constricts the blood vessels and precludes the chemotherapy to penetrate into the skin and into the nerve endings. The other typical neuropathy approach that we use more successfully is acupuncture. We oftentimes refer patients to acupuncture. There had been a clinical trial done. It's true, it was in breast cancer using chemotherapy that caused neuropathy, and half the people used acupuncture for 8 weeks, once a week versus not. And there was a 50% improvement in neuropathy. Again, I have never seen real benefit from the supplements indicated.
So would you suggest that, how would you approach that? Is that a phone call you make to your doctor? I'm interested in the acupuncture. I would like to try the ice packs. Do you show up with the ice packs to your chemotherapy?
No, the
appointment?
nurses. So in our clinic, the nurses provide the ice packs. You don't show up with the ice packs yourself. They are available in the clinic. So we do cryotherapy for every patient that receives potentially neuropathy-inducing chemotherapy. We also use it for their feet, not just for their hands. So
Okay.
the nurses and the clinic supplies that.
So
The
just
referral to acupuncture is provided by the doctor, so the doctor will refer you.
Great, thank you. Following diagnosis, is there any opportunity to actually remove the entire pancreas and replicate the pancreas's function?
So there are situations where patients have cancer throughout the pancreas, and we always try to shrink that by, again, giving systemic chemotherapy and having any remainder of pancreas. It's better than having no pancreas, because as you know, the pancreas has 2 main roles in the body. It makes enzymes to digest the food, so without a pancreas, it's going to be extremely difficult to digest the food that you eat. And second is regulating the blood sugar. So diabetes will occur, of course, if the pancreas is removed. And diabetes can have life-threatening consequences. So it's always optimal not to remove the entire pancreas and to leave as little portion possible after surgery. But if a total pancreatectomy is necessary, of course, that can be done. It's done probably less than 10% of the time. And in that case, people will, of course, need to be on insulin for the rest of their lives, as well as pancreatic enzyme supplementation.
Thank you. I have stage 1B locally advanced, did 3 cycles of Folfirinox, and then changed to Gem-Abraxane after liver toxicity. Most recent CT showed some slight decrease in size of tumor for first time, but still abutted to SMA and SMV. So I just see, yeah.
It looks like, Tanya, there might be a follow-on to that question.
Okay. Oh, there we go. How much, I see it was interrupted. Thank you. How much of a fat plane needs to be had before moving the surgery? Whipple, question mark. Is it possible tumor will be mostly scar tissue that is shown in CT after 6 months of chemo?
Yeah, so this is where the expertise of the surgeons really come into play. What I described to you about the fat plane is a cancer that's readily resectable. When that fat plane does not exist, it comes, and the patient already had, 6 months or 4 to 6 months of neoadjuvant chemotherapy, it is very possible that some of the tumor that's still there, just like my patient that I showed you that had successful operation, despite the fact that there was still a touching of the blood vessels by the tumor, most of it was scar tissue. So that's where the expertise of the surgeon comes into play, because Hopkins, University of Washington, expert cancer centers with expert surgeons, if they think it's safe that the abutment of the artery is actually small and minimal, they would definitely do an exploratory surgery, intraoperatively assessing how much of that is cancer versus scar tissue. If it's scar tissue, it basically will be easily able to be peeled off the arteries and have a successful operation. But it really depends on the expertise of the surgeon. So there are surgeons that will absolutely not operate unless they see the fat plane. And there are many surgeons with expertise that know that following neoadjuvant chemotherapy, some of the tumor may not have completely gone away, but they would still explore the patient and try to perform that operation.
Is a pharmacist on the team?
Yes, we have one that attends the multidisciplinary clinic. So they'll often point out things like, remember to look at this lab before you do this drug and things like that.
Thank you. My husband has an ATM mutation. After recurrence last fall, he tried Gem-Abraxane, then Folfirinox, but the cancer keeps growing. His oncologist is moving him to SBRT, then Opdivo. Is this a therapy you've seen after chemo fails to suppress the cancer?
Patients with ATM mutation, if they have localized disease, are exquisitely sensitive to radiation therapy. So radiation therapy has a very good chance of controlling the disease if the tumor has an ATM mutation. There is no substantial data to suggest that an ATM mutation will make the cancer sensitive to Opdivo, also called nivolumab. So that's not something that I would recommend. Nevertheless, if it's part of a clinical trial or a combination or Opdivo with radiation, I'm not against it. I'm actually the first to recommend clinical trials, but I would not recommend Opdivo to be given for an indeterminate amount of time at a cost of $40,000 an injection for no evidence of benefit. If this is again in a setting of a clinical trial where the Opdivo is provided for free, part of the clinical trial, maybe in combination with radiation, absolutely I support that. Radiation therapy alone can also be very efficient, especially again, if the tumor is localized. So I think that radiation is a great idea. Nevertheless, patients that have ATM mutation may also be sensitive to a class of drugs called ATR inhibitors. There are clinical trials available with ATR inhibitors where patients with ATM mutations benefit, especially when the ATR inhibitors are in combination with other drugs. Furthermore, cisplatin chemotherapy can also benefit. So sounds like the patient never had gemcitabine with cisplatin. They had Gem-Abraxane and Folfirinox. So that's another chemotherapy that actually can benefit. But absolutely, radiation is a good idea.
Okay, and it looks like there was a little follow-up sentence about that he did have olaparib before chemo and it didn't affect the cancer growth.
Right, olaparib is not efficient for ATM mutation. It's efficient for BRCA1 and 2 mutations. No efficacy for ATM unless you have prostate cancer.
Great, thank you. So our next question is there any relationship with development of pancreatic cancer and Helicobacter pylori?
I am not aware of any connection between H. pylori and pancreatic cancer. There is nevertheless a lot of data about microbes, bacteria colonizing pancreatic tumors, and Fusobacterium, which is a bacteria that sometimes people with gingivitis and gum disease had been discovered to reside in pancreatic tumors. So again, I'm not aware, but maybe there is some research that I haven't seen yet about H. pylori. We know that H. pylori, of course, is a risk factor for certain gastric cancers.
Great, thank you. So my wife has the following family history: mother with pancreatic cancer, paternal aunt with pancreatic cancer, maternal grandmother with stomach cancer, maternal great-grandmother with breast cancer, no prior family history genetic testing. Should my wife obtain genetic counseling?
Absolutely, 3 times or 10 times, absolutely yes. Both the history of pancreatic cancer in the mom as well as stomach cancer, raise flags about potential cancer syndrome. For example, pancreatic cancer is part of a genetic syndrome called the BRCA1 and 2 mutation, which involves breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer. So all of those types of cancers are part of the syndrome. In addition, pancreas cancer and stomach cancer, colon cancer, uterine cancer are part of a different syndrome called the Lynch, which has to do with MSI high status, which we talked about, pertains potential sensitivity to immune therapies. So absolutely, the patient should have a visit and testing with a genetic counselor.
Great, thank you. This is a question for a patient that is 3.5 years out from diagnosis of pancreatic endocarcinoma. Treatment consisted of a Whipple procedure followed by 6 months of gemcitabine. The patient has been NED since treatment. However, they have experienced intermittent fever chills. Just 1 second. These little pop-ups are coming up when I'm reading my question. Hold on.
Sorry, that's my fault.
That's Mark. Sorry about that. I'm sorry. Fever chills, sometimes 2 or 3 times a month. Are there any available treatments you could recommend for this?
Yes, so fevers and chills 2 to 3 times a month, it's a very non-specific type of symptom. So the first thing that comes to mind is this possibly, a viral illness? Is it potentially an autoimmune disease going on? Is there something else going on? First of all, every pancreatic cancer patient, especially somebody who's only 3 years from surgery, should still undergo follow-up in terms of every 6 months visits with a medical oncologist with blood work, including CT scans, until 5 years from surgery. So I assume that all the follow-up has been done and the patient has no evidence of malignancy. So fever and chills, it's definitely not necessarily a symptom that I think about when I think, oh, recurrence. It can be a very non-specific inflammation going on in the body, anywhere from a virus to something that has to do with the immune system. So I would recommend that the patient sees their primary care physician, potentially undergoes blood work testing. And again, I assume that their standard every 6-month checkups have been all okay.
Thank you. Here's another comment and question. Thank you so much for this wonderful presentation. I'm wondering about if treatment outcomes differ radically by age. For example, do we have much data on if a 30-year-old BRCA2 has different outcomes than someone who is 50? Are there different treatment protocols for age?
Yes, very good question, very pertinent. So first of all, the age per se is not really a factor that we take much into account when we recommend treatments, whether it's surgery, whether it's systemic chemotherapy or targeted therapy. All patients, no matter what the age, benefit from all of the treatments that I have discussed today. I spoke to one of our surgeons about a 95-year-old, whether that patient, just based on age alone, should or should not undergo a Whipple operation. And the surgeon told me, oh, I trained at Hopkins. I think the oldest that I've seen undergo a Whipple was 102. So this is just an example to tell you that the age per se does not matter. If the question is about are patients that are younger going to live longer than are patients that are older? In fact, sometimes younger patients may have more aggressive cancers. In fact, we do know that pancreatic cancer is supposed to happen in the 60s and 70s. The median age is in the 65, 67-year-old range. Whenever we see a young patient with pancreatic cancer, the red flag is up, whether it's something genetic going on or the outcome and the aggressiveness of the cancer may be actually worse in a young patient. We do not discriminate in terms of age, whether to offer therapies or even clinical trials. We enroll patients into trials when they're 85, if they are otherwise feeling well.
Great, thank you. Is there anything our presenters would like to add before we conclude our presentation for today?
I just want to emphasize to all patients and caregivers the real need to ask questions and to be advocates for themselves, to really use the resources of PanCAN, the Pancreatic Action Network, and to do benefit from telemedicine and have access to experts, because I feel that, again, always, like Greta said, more brains are better than one. And the more opinions and the more information you have, I feel that it's, at least we feel that we've done everything we could. And again, even if, let's say I've had a question that I've answered on the side panel regarding genetic testing or genomic profiling, even if the cancer may have been profiled a few years ago, knowledge accumulates each year. Every 6 months, every 12 months, we get new drugs that we are aware of, new options that we're aware of. So do not hesitate to, again, ask to have the most up-to-date information about your cancer that's available to date.
Cassidy, did you have anything you'd like to add?
Just echoing everything Dr. Kiorian said, it's definitely important to ask questions. I know the NCCN patient guidelines has a list of questions to ask the healthcare team. Absolutely suggest visiting that list. PanCAN also has a similar list in our resources as well. So definitely, if you don't know which questions to ask, there are resources out there to help you have that conversation and help you make that list. And definitely just, it's important to keep that communication open with your healthcare team to make sure that they understand your needs and concerns.
Great, thank you. Yeah. And Greta?
I would just say, echo both of those things. I often tell people to start your list and keep it going. It doesn't stop. It always flows into the next appointment or phone call. Thank you.
Great, thank you. I see one more question has popped up. If a patient with a BRCA2 mutation has been NED for 5 years, should he or she continue to receive follow-up, and if so, how long?
Yes, so per NCCN guidelines, we continue follow-ups for approximately 5 to 7 years after surgical resection. And that is because occasionally we do see those very late metastases that happen typically in the lungs. And for those particular situations, we recommend extending the follow-up beyond 5 years to approximately 7 years or so. So that's typically when we stop and we tell the patient, you no longer need to see the medical oncologist. Nevertheless, especially for a patient with BRCA2 mutations, they have to continue their cancer screening. And hopefully a genetic counselor, an expert, have already informed the patient of how to protect themselves from other cancers that are part of the same family. And I think this is very important, is not just the cancer that's gone and hopefully it's forever gone, but how do you protect yourself from other cancers from happening again?
And I think this, there's one more follow-up question about, again, the genomic testing and molecular profiling of a tumor. So should a patient undergo genomic testing and molecular profiling of the tumor after undergoing extensive treatment, even if testing was done at the time of diagnosis?
Correct. So as I said, the science and the knowledge evolves. And sometimes the panels that test for genetic mutations get updated with novel discoveries, especially if it's more than a year from the original test. And furthermore, as the cancer evolves, new clones of cancer cells may develop that acquire new mutations which were not present originally. So therefore, I do retest my patients, even if they were tested before. I cannot tell you how often. Sometimes the initial test said MSI status, undetermined, TMB, undetermined, or maybe they didn't even do TMB, or they didn't do RNA sequencing to look for these genetic fusions that I spoke about today, such as NRG1, because the typical genomic testing didn't have fusions panels before. So absolutely, yes, do get tested again, because again, new mutations and new technology evolves and can find novel alterations. It's rare, it's not always happening, but it's worth checking. And sometimes if patients, let's say, they don't have an accessible tumor to biopsy, tumor biopsy is a gold standard, but these days we have access to liquid biopsy, which is checking for circulating tumor cells in the blood and circulating tumor DNA that can be found and tested for genetic profiling. So do not hesitate and say, I'm not going to do this because I don't want to have a lung biopsy, or I have nothing that's easy to biopsy and I don't want to go through this procedure. In that case, a liquid biopsy can be an option.
Great, thank you so much. We are out of time today. Thank you everyone for attending, and thank you to our presenters. Have a great rest of your day.
Thank you so much. Have a good day.
Thank you.
Thank you.